is our fifth webinar on post-renal transplant de novo glomerular diseases. Today's speaker is very renowned nepropathologist, Dr. Shaila Khubchandani, madam, who is Director of Surgical Pathology and Electron Microscopy at Jaslok Hospital and Research Center, Mumbai. She is also Consultant Surgical Pathologist and Electron Microscopist at Sir H.N. Reliance Foundation Hospital, Mumbai. Consultant Surgical Pathologist at Bhatia and Parsi General Hospitals. We are eager to hear you, madam. Over to you. Thank you.
Hello, everybody. At the outset, I want to thank Dr. Radhika and her colleagues for inviting me to give this lecture on de novo glomerular diseases involving a renal transplant. Now, the word de novo itself means anew, fresh. So this is referring to diseases that would involve the transplant kidney, which are not related to any rejection pathology, and of course, that the recipient has not had as his original disease leading to renal failure. Now, these diseases take a while before they manifest themselves, and most of them come a minimum of 3 years post-transplant. And in fact, one study has demonstrated that there is a 10% involvement of the kidney at 15 years post-transplant. The commonest manifestations that the patients will come to you with will be proteinuria, either nephrotic or non-nephrotic range, and hematuria. And so it's extremely essential to know all the laboratory data before you move forward. I cannot emphasize this point, and therefore, if you notice, I've put it in bright red that pure light microscopy is not adequate for us to come to a conclusion when we are dealing with de novo glomerular diseases. We need to have all the three modalities: light microscopy, immunofluorescence, electron microscopy, a subset of light microscopy, which is immunohistochemistry also. And in case we don't have the necessary modalities available to us in any center, I would request that you collect the tissue and keep. In case we do manage to achieve a diagnosis with light microscopy and immunofluorescence, we can wait and then look at electron microscopy at a later date. So, what are the commonest reasons why you would get proteinuria? We all know that, but the commonest, of course, is glomerular disease. When it is transient or it is mild, like in non-transplant, it could be tubular function or other reasons like drug toxicity. What we are looking for is persistent proteinuria, which again could be nephrotic or non-nephrotic. Now you would notice that majority of the patients who present with nephrotic or non-nephrotic proteinuria have had some issues with rejection. And it is only 30% of cases who may have glomerular pathology, and 10% could be non-specific. Now, I have just made a small little table, but this really doesn't apply because theoretically, any disease that involves the kidney can involve a transplant kidney. But what has been noticed that maybe some diseases are a little more common than the others, and membranous glomerulonephritis is definitely top on the list, followed by all the others, including immune complex diseases, infections, thrombotic microangiopathy, metabolic disease, crystal deposition, and the rarities like monoclonal IgG deposits with proliferation and even minimal change disease. Now, we tried to find, some of this data at our hospital. And this time I did pull in even Reliance Hospital where I've been working. But I ran into multiple issues, and the most important being that very often we do not know the primary disease, because a large number of our patients do present to us with very late involvement in which we do not perform the biopsies. So that is an important criteria, which in fact prevents us from this, specific classification of whether the patient has had a recurrence or a de novo disease. Also, in some situations, it is not always possible, even if the tissue has been collected for all three modalities, to not be able to process these, and therefore we cannot reach a specific diagnosis. So I'm going to try and illustrate a few of these diseases through some of the cases that we've been exposed to. Now, this was a very charming young dentist who unfortunately had headache, backache, raised blood pressure. Creat was almost as high as 5.41, which went up to 6.2. Her serology was completely negative. And you can see at the biopsy that she definitely has proliferative disease. The entire glomerulus is packed with cells, including neutrophils. So we have endothelial, mesangial proliferation, and a crescent. Likewise here, significant proliferation, almost no lumen available, and that would explain why our creatinine was so high. At immunofluorescence, there was strong IgA greater than 2+, and so we gave the diagnosis of a IgA glomerulonephritis, but of the crescentic type. And one knows that any disease with crescents always has a little worse prognosis if we don't get the disease in time. And that is what happened to this poor lady. Her disease progressed, and eventually, very quickly, in fact, within 2 years' time, she needed to have a transplant, and a transplant was performed. It was she received a ABO incompatible live transplant, and it was on day 3 that her creat started increasing, urine output started decreasing, and hematocrit started falling, which raised all the alarm bells, and immediately a biopsy was performed. You can see over here that every tubule is packed with hemorrhagic material, and every tubule is showing necrosis. There is a glomerulus here, which is barely visible. There is fibrin material. And in fact, I had a doubt as to whether even there is this glomerulus is going into an infarct, but I could see the nuclei, so I left it as mere congestion. There was fibrin material. There was marked dilatation of the vessels. There was basement membrane thickening. And if you see over here, there was double contouring. So this all led to the fact that this histology presentation was that of a TMA, a thrombotic microangiopathy. And as you are aware, you can get a TMA presenting to you in a definitely in a humoral rejection, the acute variant, and a primary TMA. So and her condition deteriorated so much that led the clinician to perform a nephrectomy. Otherwise, she would have done very badly. At nephrectomy, you can see that her glomeruli were completely showing infarction. The tubules around were also infarcted. And with a great degree of difficulty, I found some areas where there was viable tissue. And again, the same story. See this blood vessel with fibrin material and foamy cells and very, very swollen endothelial cells. You can see in this glomerulus, fibrin material, and the loop is completely distended. Likewise, what you can see over here. This stained with PAS, you can see, has resulted in marked distension, is what another term that we like to label this with is mesangiolysis. And there are many capillary loops which do not have any red blood cells, or perhaps some very swollen cells, and basement membrane thickening. And so therefore, this was definitely a case of histology presentation of a thrombotic microangiopathy. The vessels gave up the entire diagnosis to us. You can see the marked myxoid change over here. The lumen has become so tiny. You can see normally you don't really see the endothelial cells, but see the endothelial swelling. You can see the red blood cells, which have got fragmented here, some degree of fibrin-like material. Over here, there's another vessel with fibrin material. And at electron microscopy, the entire loop was packed with swollen endothelial cells. And in the basement membrane, you can see the vacuolization of the lamina densa. There is no fenestrae that you can see of the endothelial cells, possibly one remnant over here. And so therefore, this was a case of histology and electron microscopically a case of thrombotic microangiopathy. Strangely, the immunofluorescence did not show too much of fibrin. Now, because of this entire story and persistent negative donor-specific antibody levels, I requested the clinician to do the genetic studies, which we received almost after 3 weeks, which confirmed that the patient had the necessary genetic alterations for a thrombotic microangiopathy. So this was a case of an atypical thrombotic microangiopathy occurring in the transplant kidney. Now, before I move on to just give you a little explanation, it is extremely imperative, not only in the routine biopsies, but in a transplant kidney, because the histology appearance can be mimicked by a humoral rejection, and we need to separate the two. And so, of course, the clinical data, along with the laboratory, where you need to have at least one or basically two of the features over here, which you should be seeing before you can even start suspecting it clinically. At histology, most often you get bloodless dilated capillary loops, basement membranes are thick, you get mesangiolisis, the vessels show severe edema with a mucoid change and fragmented red blood cells. Immunofluorescence does show fibrin. Electron microscopy, the characteristic finding is subendothelial widening with fibrin, endothelial cell swelling with the loss of fenestrae, GBM duplication with mesangial interpositioning in slightly later cases, not in the very active disease. So actually what had happened to this patient, and I was completely lost because being just a simple pathologist, but after doing some reading, I realized that it is IgA-GN, which does have some degree of complement alterations. This was forming the basis of a disease process, which if left alone, nothing would have happened. Onto this, we had transplanted this poor lady with a ABO incompatible kidney transplant, and she had a genetic background. So it was like a double whammy that hit that kidney, resulting in this thrombotic microangiopathy. Now, sometimes there are other reasons, and in fact, in our last 5 years, we've had a few unfortunate incidents where a patient who came and expired suddenly, both his kidneys were donated to 2 different donors. Both those donors had a TMA. Now, the commonest cause, of course, are the immunosuppressive agents followed by the infections. Genetic causes are extremely late, and I have just put antibody-mediated rejection below the line over here because at histology, the the presentation can be identical, but you have other features. You have to show the presence of DSC and C4D positive. Sometimes C4D may not be positive, but you have to look into DSA before you label it as antibody-mediated rejection. On the wake of this poor dentist lady of ours, we had another patient, a 48-year-old lady who was a known diabetic, who had received a transplant about 6 months ago. And immediate post-transplant, she never really had a nice, good baseline creat. It was always marginally elevated, ranging between 1.5 to 2. And then she developed this severe urinary tract infection with diarrhea and came with graft dysfunction, which never could be kept under control because in spite of the antibiotics, her urinary tract infection reduced, her diarrhea reduced, but her creat never came down. And in fact, she started deteriorating so rapidly that another nephrectomy had to be performed. And in this case, what did we find? We found that the blood vessels, the renal artery that was supplying the kidney was showing fibromuscular dysplasia. Can you see the green highlights the fibrous tissue and the marked increase and the thickening of the muscle coat, like you see over here. So the reason I have kept these back to back is just to put this thought into the mind that yes, we have labeled it as de novo, as a new disease that is coming to the patient. But this patient who received this transplant did not have any changes in the renal vessels, received it from the transplant, and so got this due to donor disease. Until a few years ago, we didn't even consider anything as, donor disease. But now it is imperative for us to also put another dimension when you're looking at the transplant patients, that yes, even donors can contribute to some degree of changes involving the transplant kidney. Yeah, I just put this here just to emphasize my point again. And this is a picture by a very famous artist, another picture by another famous artist of the same lake. And one is by Monet and one is by Renoir. So all that I'm trying to say is that the end result is the same. The histology may be the same because it will just show you an infarct, but the cause of the two are completely different. And that is something I do want to emphasize before I move on. Another reason why we lost another graft kidney was because of so much of heavy infestation by this parasite, or Wuchereria bancrofti. This had distended virtually every lymphatic in the poor kidney, had compressed the renal artery, resulting in infarct. This makes me move on to the next important causes of involvement of the kidney, de novo sometimes due to certain other situations, resulting in infection of the transplanted kidney. Now here, you would be able to see that there are so many nuclei lining the tubular epithelium, so enlarged because of some material that is present over here, which is the viral inclusion. And so to tell you the truth, this is a simple H&E diagnosis, but now we have all these new things available to us. So we can do immunohistochemistry to absolutely confirm that it is cytomegalovirus. And because I have the EM, I invariably go ahead and do it. And this was done from the paraffin block. And so you'll see a little bit of alterations in the fixations over here. So cytomegalovirus, of course, can come as a fresh infection, but it can also come as a reactivation, either from the donor or from the recipient. So that is something very important to remember. And this is easy to understand. But CMV is also a great contributor to post-infectious glomerulonephritis, which occur in the transplanted kidney. And in these situations, the patient can even manifest with any histology changes. Sometimes the patient may even have an IgA nephropathy, an immunotactoid GN, or just a simple crescentic GN. You can see here there is a focus of necrosis, there is an ill-defined granuloma formation, and again you can see the swollen lining epithelial cells of the tubules with a small little vacuole over here. And this is classic adenovirus involving the transplant kidney. Another example of a different organism, can you see these fungi which are present in the tubular lumen? See this fungus over here, little rounded and branching. And because of this, I can tell you, even at histology, which now, of course, is not a good idea to be specific about, but I can say that this belongs to the family of Candida because now we are able to culture them and give a specific diagnosis. So fungal involvement is also extremely important. And here I've just kept another fungus over here, which is branching at acute angles. And so whether it was aspergillus was my question, but of course it turned out to be non-aspergillus. Moving on to, as I mentioned in my story over there, the commonest cause of a de novo glomerulonephritis is a membranous GN. And you can see over here, normocellular, thick basement membranes. You can see the splitting that has taken place here with the small little hair-like protrusions, the strong IgG granular along the capillary loops, the prominent subepithelial deposits at EM, and strong C4d positivity at the periphery. Now, you will ask me, why have I put C4D over here? Because it is extremely important to have the entire armamentarium available to you. Because every case I will not be lucky in every situation to have all these things happening. In fact, transplant biopsies are extremely erratic in their behavior. They may not show IgD deposits, or they may show IgG deposits, and it's extremely difficult to find subepithelial deposits because the deposition may not involve every glomeruli uniformly like we once thought it did. And the earliest method of demonstrating these deposits is by doing the IHC staining for C4D. And so it is extremely important. And here again, therefore, I emphasize the need to have, or the availability to have, every modality with you to come to a specific diagnosis. Now, de novo is supposed to be, or has been noted to be, twice as common as the recurrent diseases. And in the entire gamut of de novo disease involving the glomeruli, it accounts for almost about 9%. But it's a very indolent disease and so does not present immediately. And very often these patients stay with this membranous glomerulonephritis and nothing actually ever happens to the graft unless there is a second hit with some other disease. Now, there are various theories as to why, but we still don't have a single reason why, unlike now in our primary where we have all the new antigens that have been detected. In fact, PLA2R positively is very rarely seen in the de novo membranous nephropathy. And the commonest subtype of IgG that one gets is a IgG1. And we did have a patient who presented with massive proteinuria almost on day 3 or 4 of the transplant. We were almost certain that this is a proper recurrent focal segmental GN. Glomerulo-sclerosis, but it turned out to be that the patient had membranous GN, which was contributed to him by the donor. The other common disease which you may get commoner as a recurrence than a de novo is IgA. In fact, IgA de novo is extremely rare. And the incidence of HSP and IgA are almost identical as a de novo disease. And you must remember one very important thing, that IgA can be present in the donated kidney because deposits have been known to occur in asymptomatic patients. And rarely, as I mentioned earlier, you can have an immunofluorescence negative, you can have an immunoperoxidase negative for IgA and see it only at EM or vice versa, and it may be extremely weak. One important issue to remember is that if the patient presents with crescents, and for some reason de novo patients do have a higher incidence of crescents, their outcome is invariably poorer than the others. But most often, even with de novo IgA, unlike the rest of IgA, most patients do well. However, we don't really have too much exposure or experience of this in our Indian literature. And in my small little study that I did, I found that IgA disease is not such an indolent disease as mentioned in the Western literature. Now, coming to I'm sure you all are very happy to see this glomerulus because you recognize it as near normal, and all of us are so happy when you see this, because then you can say that, oh, wonderful, this patient has, if of course the other criteria are met with, minimal change disease. And that electron microscopy shows you this prominent foot process flattening, microvilli formation, and normal basement membrane with normal cellularity. But again, even under routine circumstances, to diagnose a podocytopathy, you need to have other changes to come with to help us to separate minimal change disease from FSGS. And if you are fortunate and you do get the area of sclerosis, then you can be specific and talk about FSGS. If, on the other hand, you have some degree of chronicity in the interstitium, tubules, and vessels, again, you can favor FSGS. If you don't have both, then unfortunately, either a second biopsy after, of course, you utilize the entire core with deeper sections, or only time will tell you about the progression of the disease. And in de novo patients where the proteinuria has come later on, much later on than immediate, in the recurrent FSGS patients, these diseases definitely take far longer, and the proteinuria starts slowly. So it is most often possible to separate the recurrent FSGS from the de novo from the time frame itself, the possible proteinuria which goes up slowly, as well as the creatinine levels which go up much slower than those with recurrence in most cases. Now, de novo FSGS can present as I showed you in the picture, but in addition to just as well, I don't even know whether I can call it a primary disease, it can also be seen in patients who've had hyperfiltration injury, where maybe we've been a little very aggressive and we've used a young individual's kidney to be donated to an elderly person. And then you find that there is, for example, a pediatric kidney in an adult recipient. This doesn't happen very often in our country, but a rare instance. Then this is the time that you have to be looking out for a de novo FSGS. And if the patient has been getting significant loss of the nephrons, which happens a little late in the stage of the transplant, then of course we can have an explanation for de novo FSGS. Collapsing glomerulopathy is also seen as a de novo disease, and most often this is associated with some degree of ischemic damage or damage to the vessels. And so I have to re-emphasize this again and again and again, that all our criteria that we use for the diagnosis of all our conditions in non-transplant patients cannot be held true in transplant patients. So we may have to call something as FSGS without any of this. And we may have to, in a case of membranous, call something as membranous without EM deposits, without C3, sometimes very faint IgG, and only rely on C4D, which also may not uniformly stain all the capillary loops. Just another picture to show you. Here we have diabetes. Can you see this little nodule formation, involvement of both the efferent and the afferent arterioles, nicely seen on PAS, thick basement membranes. Congo red, of course, was negative. You can see the vascular involvement, and this is diabetes. Now, diabetes, commoner is recurrence than de novo, but de novo can also come thanks to various other reasons, metabolic syndromes, etc., in this patient, which we all are undergoing in this new age of ours. And so de novo diabetes is also observed now to a slightly greater extent. I'm going to move on to this case, but I'm afraid I'm not going to be able to read all this. But suffice it to say that this was a lady who had been diagnosed with lupus 10 years ago. She was on steroids, immunosuppressives, but I must say that she was a little, erratic in her coming for checkups and taking her treatment. And she eventually resulted in giving her renal failure, and she had to go on dialysis. No biopsy was performed at that time, but she was obviously a case of lupus, and so it was presumed that it was lupus involvement which resulted in her kidney disease. A renal transplant was performed. Her mother was the donor. It was an ABO incompatible. She was put through the entire rigor of getting all her immunoglobulins down, but post-op, her immediate period was uneventful, but then her creat started going up, and so the first biopsy was performed. And what did we see in the first biopsy? Literally, the only thing I saw was tubular injury and these hyaline thrombi, hyaline material everywhere in the loops of the glomeruli, in the vessel feeding the glomeruli, and in the other vessels. Of course, C4D was negative. Her creatinine then continued to rise. Her DSA stayed negative. ANA was barely positive, faintly in one because we did the immunofluorescence. By serology, it was completely negative. But in any case, seeing all those diagnoses, I offered the diagnosis of active humoral rejection, or I just said this could be a TMA, because when I found that the DSAs were negative and my C4Ds persisted in being negative. So second biopsy was done, the same story, again, just fibrin material, and marked dilatation or mesangiolisis. So why was this not a TMA again? Another vessel here showing the fibrin thrombi, little bit of irregular thickening of the basement membranes, but nothing doing with all the treatment for TMA, for humoral rejection, because the clinician didn't want to take any chances. The patient just wouldn't have the creatinine coming anywhere. It would just be going upwards with severe tubular injury. And she was treated with 5 plasma exchanges, but her creatinine remained at this level. And being a young lady, they did not want. Finally, the third biopsy, and you'll tell me that, oh, what are you doing? You're just showing me a similar picture. Again, fibrin thrombi. So much of myxoid change with breakdown of the RBCs, breakdown of the RBCs over here. Again, definitely not showing all the clinical changes, laboratory changes that I need in a TMA, but finally, even the platelet count was normal. There were no schistocytes, but at this stage, she showed APLA positivity. So herein we were with a patient of lupus whose lupus serology, lupus manifestations were completely in control, because now she was regularly following up for lupus, and she developed an APLA. Now, the reason I have put this is that it is not possible for us to every time pigeonhole all our diseases. And we have to remember the entire gamut of differential diagnosis that we have, because otherwise, in an area which you are, you would try and put that disease into that process, which is what I tried to do. And so I want you all to learn from my first two errors that APLA never struck me for me to tell the clinician. Of course, I wrote it in my differentials that a thrombogenic disease could be the cause of these thrombi that you're seeing over there, but a specific lookout for APLA was not performed. And I think it is very important to remember that diseases evolve, but in this situation in the transplant, the diseases don't evolve as we know them to be. And so it is very important for various areas to put every possible data that you have, the clinical data, the laboratory data, the light microscopy, immunofluorescence, immunoperoxidase, electron microscopy, if need be, some molecular data to find the exact etiology. Because if we don't find that, we can never treat our patients. And I would say sometimes the transplant does behave as erratic as does this very, very famous painter, Michelangelo. And I think the transplant also has the same degree of arrogance, because he never signed out his name. All he did was he put a drawing of himself over there. And if y'all are interested, go ahead and search for my painting and my own picture over there, and then you'll know it's a Michelangelo. And I think that's what the transplant is trying to tell us, that listen, you've taken me out from somewhere and you're putting me here. I'm happy to function, but please look at all possible evidence available to you before you can come to a specific diagnosis. So thank you so much.
Thank you, respected madam. It was very enlightening class. And thank you for sharing all your actual images with the actual cases and so much vast experience in the field of nephropathology, including electron microscopy. I hope everybody would have enjoyed this class. Can we take questions, madam?
Yes, of course. Most welcome. In fact, I would love to have some questions.
Yeah, there are few. So what is the most common de novo GN in graft biopsy?
Well, even with us, and if I put aside the infections, of course, you're asking for GN, the commonest is membranous glomerulonephritis. And our second still remains to be focal segmental glomerulo-sclerosis. For some reason, that incidence has increased to, such a volcanic proportion, and it seems to be happening even in the transplants.
Yes, ma'am. How to differentiate between de novo and recurrent membranous nephropathy?
Yeah, so, I did put up a slide to just show you that we had made an attempt, but there are 2-3 things which are happening. At least I find with, in my center for sure, the 2-3 that I work with, that a large number of our patients, we cannot, come to 100% conclusion about their pre-transplant status and disease, because they do come to us fairly late. And unlike Mass General, which take out every kidney of, the transplant, affected kidneys taken out before the transplant is done. So we are never really sure. But having said that, a few clues do exist. And one is that they do come much, much later on than the recurrent diseases. And they seem to have a slower transition. And that definitely holds true for membranous, and that definitely holds true for FSGS. So if a disease has come most immediate, then I would say that it's better to err on the side and say you're looking at a recurrence rather than de novo disease.
So should we do C4D staining in native membranous nephropathy, according to your experience?
Well, it's like this. If you have, everything fitting in which you like I said, the jigsaw puzzle where nice proteinuria, relative adult, everything else looking neat and nice. Of course, if you have a FSGS lesion or, tubulointerstitial chronicity, then you can't help it. But most often membranous doesn't do that. You have a nice IgG, kappa, lambda, then you don't really need a C4D. But it's in those cases when you are seeing little irregular basement membrane thickening, your other differentials, say a TMA, or none of those are coming into the story, then I do recommend, and at least I have found that a C4D really helps you very often. And specifically, if you get a faint IgG, then you start getting worried that, oh my God, when I should be having a nice 2+ at least, I've got it very faint. But with a C4D, you feel good that, oh, this is 100% only membranous. So I do recommend it. I understand it adds a burden to the patient, but if possible, it should be done. For some reason, have not found a very good, association with our immunofluorescence C4D in membranous. That seems to work very well in the transplants. Yes, it does. You do get it, but somehow the IHC works better in my laboratory, my technician's hands. Let me put it that way.
Does recurrence of FSGS in post-transplant have less than 80% food process effacement due to CNI and steroid use, according to your experience?
The thing is that, to tell you the truth, I'm a little worried when they keep telling us to differentiate between primary and secondary disease in FSGS, because the first rule is that the patient should have had no treatment, meaning no steroids whatsoever before, and you have to have 90% food process flattening. So that combination is extremely rare. At least in my hands, I have found that I can never ever be sure. And even after speaking to the clinicians, sometimes patients have gone from one city to another, and they do mention that they have received the steroids, in which case we are not really justified in calling it as a primary, even if you see it as 90% food process flattening. But I do mention it that since there is a significant food process flattening, which I feel once it's over 80%, there is no harm in suggesting that this could be a primary disease. And when you have excluded that the patient doesn't have diabetes, doesn't have obstructive renal disease, and does not have any other reasons for him to have or her to have a secondary disease, then of course you can think of it as primary disease as opposed to secondary. But no real criteria have come out to help us to separate primary and secondary FSGS in a post-transplant, aside from what we have done in the primary diseases in non-transplant patients.
Many congratulatory messages are also there. Excellent presentation. And we see one question is there. We see many ATN cases in biopsy when it is done for slow graft function in early post-transplant days.
Yes.
No evidence of rejection, Doppler showing good flow. We find it very difficult to find out the cause of ATN. Is it TAC toxicity or ischemic injury during implantation? Ischemic timings are within acceptable limit. So as these are live related transplants, on this they are asking the thoughts from Dr. Sandeep Kumar Panda, sir.
Yes. So Dr. Panda, I mean, I can imagine, because the same thing we are going through. Luckily for us, it is the, tubular injuries, which are, though I'm not now allowed to call it necrosis, I have to call it as injury. So all tubular injuries are, and in fact, that has become the commonest diagnosis, which is nice because at least there's hope that, it will resolve. We recently, about 3 or 4 months ago, had a case where Dr. Bahadur kept coming. Have you done the BK virus? Have you seen this? Have you seen that? Because whatever came to his head, he kept coming to ask me that, is that the reason for the ATN? We never ever found a reason. The patient stayed in the hospital for over 3 months. And finally, at the 4th month, the creat slowly started coming down and came to normalcy. And therefore, at that time, I did do a lot of reviewing of the literature. And what they did mention was that there are some reasons. And, they went into a lot of molecular biology studies, but nobody as of now has come to give us a straight cause-effect relationship with tubular injury. And tubular injury still persists as a very, very difficult entity to, first and foremost, not to diagnose. It's one of the easiest for us and the happiest for us, but to look after such patients. And it can persist even as long as 3 months. So I'm really sorry, I have no explanation as to why we have this kind of an ATN. The only thing that could be said, which in one article did come up to say, is that individual responses to regeneration may alter, and and just one mention came about the donor kidney. If that patient has been having some degree of vascular involvement wherein the lumen of that vessel is reduced, and in sometimes in our marginal donors we do have some degree, these are the patients who take longest to recover.
Thank you.
This was the only thing I read in literature. And of course, I keep troubling my poor professor with all these questions. And he said, listen, there's really, as of now, no answer to this. This is my professor and Mass General, whom I keep bugging at the slightest opportunity when I come to a doubt and run into a blank with literature.
Yes, true, madam. Ma'am, donor-derived GN, how to suspect like prior? Is there any, what is your experience like?
Yeah, so there is just no way to suspect it other than in the time profiles. So all I would like to emphasize over here is, at least what I like to go by, and with all my reading and some degree of exposure that I've had, is that recurrences tend to come a little earlier, and they do come, significantly with a stronger degree of involvement, even clinically, as opposed to the de novo diseases, which come much, much later on. And in fact, in that little study that I did, none of our patients who, all these patients came only after 3 years. And then did they come with some manifestation. Till 3 years of age of the transplant, the patient was doing very well, and then slowly started having these. And you must remember that we are not, at the end of the day, here we are sitting and classifying. So it makes us feel good that we've given a label and a name to it, and so we know what to do. But please understand that the moment you've taken the kidney out of a donor's body, senescence is going to start to come in instantly. And so here we have one process going on in parallel and a second process happening. And the two processes, one may increase over the other and give rise to a greater involvement. And by that, I mean specifically when it comes to tubular injury and FSGS lesions. So I would say that basically this, I'm going to have to just put back to the clinician that you have to help us with the clinical data before we can tell you. Because on histology, if we are lucky and all criteria are there, we can give you a specific diagnosis. But whether de novo or recurrent, you have to help us to put the pieces of puzzle together. I would say that is important.
Yes, ma'am. Any particular reason for formation of hyaline globules in kidney? The biopsy of SLE patients with fibrin thrombi.
Yeah.
So,
So lupus is a very important cause for secondary aplas. And so, in fact, it should have struck me. I mean, I'm dealing with so much of lupus that I should have immediately mentioned. But all I did was I just put that whole list of, thrombotic diseases that can happen. And then the clinician went through, Dr. Gandhi, he went through everyone and finally said, let me do the aplas because of the lupus, and found this apla. And that too, the apla was very faint. It was really, had it been in any other patient, possibly he wouldn't have even put too much of weightage to it. But because of this whole story and the histology and the fact that everything was negative for a humoral rejection and a proper TMA, he looked at it from the angle of apla and gave the necessary treatment to this lady.
So last two questions we'll take.
Yeah.
What do you mean by contribution of donor in recurrence of membranous nephropathy?
No, I didn't mean, I just meant that we had this one patient who came to us with membranous GN, and we realized that it had come from the donor itself. So it was not a recurrence, nor was it a de novo, because it came so quickly that it could not have been a de novo disease. And for recurrence also, it does still take that much time by the time the antigens form on the basement membrane. It came so quickly that, as I told you, the diagnosis was of FSGS only, because very few conditions come so quickly, one of commonest being FSGS. So I'm sorry if I, misled you over there. This was just a mention to be made over there that, and I strongly feel, very, very strongly personally, that we have to look at it from the patient's angle and the clinician's angle, and not just a surgical pathologist where you just say, oh, this is de novo. At the end of the day, we have to be able to decide what has gone wrong to let the clinician know so that he and she can look after the patient. And so therefore, donor disease is now an extremely important criteria to be kept in mind before you label anything as the glomerulonephritis that you have seen. This specifically applies for IgA and membranous glomerulonephritis.
Yes, ma'am. So last question we'll take. Subendothelial and submesangial deposits elicit string in immunoinflammatory response, but subepithelial deposits will elicit mild or not at all. Any comments on this?
Yes, that's very, understandable, because the subepithelial have formed 99% of the times with the basement membrane acting as the antigen and the immunoglobulin coming and sitting on top of it. And it is on the external side, not coming in contact directly with the flow of blood. Of course, it does it doesn't come in contact with blood, but it does come in contact with the immunoglobulins circulating in the areas around in the Bowman space, but to a much lesser extent. And it is the subendothelial and the mesangial deposits which have possibly formed as antibodies somewhere else and have now got secondarily deposited over here in most of the diseases which are immune complex mediated, and lupus being the absolute perfect example for that.
Yes. Thank you, ma'am. Excellent images. I am reading the messages from the attendee. Cases, paintings. Thank you so much for sharing the brilliant messages. And there are few questions, but those are on recurrence of glomerular nephritis. So we'll take in the subsequent classes.
Sure.
Sure, ma'am. Thank you, ma'am. Thank you. Thank you, dear all.
Thank you very much. I thoroughly enjoyed myself, and I love teaching. So this was a wonderful.
We are seeing it like the glow when you're talking and answering the questions. So it's visible. Thank you very much, ma'am.
Thank you very much. Good night. Bye.
Bye.